Hi, this is Nursing It, and today's discussion is on pediatric GI disorders. The main concerns with pediatrics that have a gastrointestinal disorder are that they are at high risk for things like aspiration, fluid and electrolyte imbalances, nutritional deficits that will then impact growth, pain, impaired elimination, and altered body image. So our priority goals are to help them achieve as normal a life as possible until the issue can either be corrected or hopefully, we find some sort of adaptive measures to help them cope. Failure to thrive is a sign of inadequate growth that results from the inability to obtain and or use calories required for growth. So a weight that falls below the 5th percentile for the child's age on a normal growth chart. Failure to thrive can be related to numerous causes from inability to absorb foods, inability to eat, or even up to abuse and neglect. Regardless of the cause, treatment is always directed at reversing the malnutrition. Our goal is to provide enough calories to support the catch-up growth. Feeding children with failure to thrive oftentimes requires kind of a return to normal nutrition. Take, for example, the child in this photograph who once was very healthy and then, was not. And in this case, this was a neglect case. Not only would we need to report this, but when we reintroduced foods, we couldn't just reintroduce automatically normal foods. We would have to start with kind of bland or softer foods and work our way back up. So we're going to start kind of at the top of the GI tract, which is the mouth, and work our way down. And I should have probably prefaced this by saying some of these pictures can be a little shocking, but I think it's important to just understand that there are a lot of cleft malformations that occur throughout the entire face. This can include the mandible and the maxilla, so the bottom or the top of the jaw, the lip, the palate, the nose, the cheeks, or even the eyes. And if you think about embryonic development, the fetus, as it's growing, actually has kind of two halves of the head that come together and close right down the middle. And what you're seeing on these clefts is a failure to close during embryonic development. So this is kind of a in utero issue. They can appear separately or they can appear together. Surgical correction is done as soon as possible to minimize nutrition problems, infections like otitis media, and to maximize normal speech development. Patients who have barriers to accessing healthcare may not be able to achieve closure as an infant or a child, like the children that you see in this picture. Cleft lip is the incomplete closure of the cleft of the lip itself. And again, it could be associated with the nose, it could be associated with the teeth and the jaw or the palate as well. Care of the patient with cleft lip requires really a multidisciplinary approach. So as soon as it is recognized, which is often with ultrasound in utero, we start planning the care of this child because nutrition is so critical after delivery. So pediatric plastic surgeons, ear, nose, and throat surgeons, pediatric geneticists, speech-language pathologists, occupational therapists, orthodontists, nutritionists, nurses and nurse practitioners, registered nurses, social work managers, and pediatricians all collaborate together to provide the resources that this child and the family need for a healthy repair and recovery. So you see here the child on the right is born with a cleft lip, and then through surgical repair they end up with an incision that heals. The child on the left is wearing what's called a Logan's bow. So this is actually holding the suture site together so that after surgery, there's less tension on the incision so that it can heal without pulling apart. So this just decreases pressure on the incision. It's very similar to the use of an abdominal binder for somebody who has had abdominal surgery. Here's another example of a child who's undergone surgical correction of a cleft lip. And again, this is done at about 2 to 3 months of age, but at major surgical centers, such as Shriners and other big hospitals, they use this kind of splinting technique ahead of time, as you can see in the pictures kind of down to the side and around the bottom here, where this infant is wearing a splint that is pulling the two sides of the lips closer together prior to surgery. This reduces the tension on the surgical site and decreases the need for the Logan bow after surgery. It also decreases the kind of damage or disruption of the vermilion border, which is the lining of the lip. And so you can see here that this child has had an amazing repair done to him afterwards. Our goals to protect the surgical line or the suture line after surgery are usually met by providing elbow restraints. So rather than tying the arms down, we just put little restraints on the elbows. Oftentimes they look like pool floaties, they inflate, or they are kind of like a rigid splint that the child is co-band or gauze to, and this keeps them from being able to bend their elbows. That way they can't actually touch their face. You know, when you have a scab or a scar that's healing and it itches, what we really don't want them to do is poke at or hit or scratch the surgical site while it's still healing. And then I showed you the picture of the Logan bow. If the cleft is in the palate, then feeding becomes a priority prior to repair. And these are actually closed later on at about 6 to 12 months while the palate is growing. So they need additional tissue to kind of form before they can close these effectively. This means that there might be an effect on speech development, especially if the child has started babbling or speaking prior to closure. For feeding, it's important that we use modifications that are appropriate for the child's needs because we could have failure to thrive or just growth failure in general. Feed with the head in an upright position. Use special nipples or other feeding devices. The nipple would be cut with a slit in it or a very large bore wide nipple, so the infant only has to swallow, they don't have to suck. So basically if they put it in their mouth and they compress on it all with their gums, it will leak and they can just swallow. You can also use a spoon or special devices, and then they can breastfeed, but oftentimes they might need to pump. Mom would pump initially to stimulate milk letdown, or the mom could pump and feed with a specialized feeder. Good mouth care is really critical, and speech therapy as well. And since food can get up into the nasal cavity and easily into the eustachian tubes, things like ear infections and sinus infections are common. Moving down, looking at problems with swallowing. So esophageal atresia or EA and tracheoesophageal fistulas or TEFs are failure of the esophagus to develop as a continuous passage from the mouth to the stomach. These can occur separately or in combination, having both an EA and a TEF. Really, it's the responsibility of the nurse to notice this deformity immediately, and we see this with problems feeding. Observe the first breastfeeding or bottle feeding to see if there's any choking, coughing, or returning through the mouth and the nose. And oftentimes the first feeding will be ordered as dextrose and water if they're bottle feeding to prevent aspiration of formula. The clinical manifestations of tracheoesophageal fistula and esophageal atresia are excessive salivation and drooling, and then the 3 C's: coughing, choking, and cyanosis. The child may experience apnea, they might have respiratory distress after feeding, and abdominal distension. Airway is a huge concern, so monitor for respiratory distress and prevent pneumonia from aspiration. Place them in an NPO status and give them a pacifier to self-soothe. Swaddling and cuddling is a great idea. Suction to prevent aspiration. Elevate the head of the bed at 30 degrees and provide IV fluids and antibiotics. After surgical repair, which they do an end-to-end anastomosis to reattach the two ends of the esophagus, the baby will need G-tube feedings until the stomach, or the esophagus rather, is healed, and then they can begin small, frequent oral feedings, starting with sterile water. Since this is an open chest procedure, the baby will have a chest tube after the end-to-end anastomosis, and so they will also need chest tube care, monitor for pain, pneumonia, and any evidence of a pneumothorax. Gastroesophageal reflux, or GER, is not always GERD, is defined as the transfer of gastric contents into the esophagus. And this occurs in everyone, but just to a different degree. So the frequency and persistency of this problem may make it abnormal. It occurs with high incidence in children who have neurological impairment, hiatal hernias, repaired esophageal atresias, or morbid obesity. The treatment is small, frequent feedings, bubble and burp frequently, meaning, give them an ounce at a time, stop, allow them to sit and rest so the gas can rise, and then burp them. If you try to burp them while the gas and bubbles are still down in the stomach contents, it will actually raise the feed up with the gas and cause them to spit up more frequently. Elevate the head after feeding, but keep the body relatively flat, so like supine with the head elevated 30 degrees to avoid bending at the waist, which would put more pressure on the stomach and actually increase reflux. The therapeutic management really depends on the severity. So if the infant is thriving, we just kind of watch it. Some children will require small, frequent feedings and even thickened formula and frequent burping. Again, positioning is important. And then there's drugs that we can use like H2 blockers, proton pump inhibitors, or prokinetics like Reglan. We know, however, though, with the H2 blockers and the proton pump inhibitors, that those also inhibit the absorption of calcium, and that can then cause long-term problems. Surgically, they can do fundoplication to decrease the amount of material that actually can be refluxed. Pyloric stenosis is at the other end of the stomach, and this is a problem when it's a congenital defect that causes enlargement of the circular pyloric muscle at the outlet of the stomach, leading to constriction of the pyloric sphincter with obstruction of gastric outlet. This is actually the most common cause of infantile surgery, and they're usually symptomatic by about 2 to 3 weeks of life. So you see the onset of this fairly early on because it enlarges fairly quickly after birth. The clinical manifestations really are hallmark. They give this away, and it's not anything else. It's this: projectile vomiting. After every feed, and they're starving, they're so hungry, they just like feed, and then, they just splatter. I mean, it's projectile vomiting, not just a little bit of spit up like the cute kid in that last picture. A palpable olive-shaped mass in the right upper quadrant of the abdomen. So you think about where the stomach is and how it empties. The pylorus is large and round, kind of like a donut sign, they call it as well, but it's an olive-shaped mass. Weight loss because they're not getting adequate nutrients. There's no evidence of pain or discomfort because this does not hurt. They're just kind of obstructed, except that they're chronically hungry. So as soon as they vomit, they're going to show signs of hunger and want to feed again. They'll also have signs of dehydration because they're throwing up their liquids, and this can cause metabolic alkalosis from the loss of the stomach acids, as well as hypokalemia. And so we may see failure to thrive with these infants. The treatment for this is restoring hydration and electrolytes, and so that might be PO or IV, but probably IV until surgery. Position flat or with the head slightly elevated, and protect from infection and aspiration. Pre-op teaching, you're going to explain to the parents about nutrition and the positioning and the care, what the surgery is going to entail, and this is called a pylorotomy. So here's a picture of kind of pre and post to pylorotomy. So you can see how on the left hand side here, before the surgery, the pylorus was swollen inwards and was obstructing outflow from the stomach. And then what they do is they go in and they actually incise the edges around the pylorus, allowing it to bulge outward, and so then it no longer pushes inward and allows for gastric emptying afterwards. Postoperatively, provide IV fluids, pain management. They will have an NG tube because they just had surgery on their stomach. Feedings can be instituted within 4 to 6 hours if it's laparoscopic. And they may not even have an NG tube if it was laparoscopic. They will have one if it was open. And then begin small frequent feedings of clear fluids followed by formula or breast milk as tolerated. And lastly, Hirschsprung's disease. So Hirschsprung's disease is also referred to as congenital aganglionic megacolon. And this is where there's a segment of the colon that doesn't have any ganglion cells in the colon or the rectum that leads to failure of the internal anal sphincter to relax and no peristalsis in that area. So it causes a mechanical obstruction from inadequate motility. This happens in about 1 in every 5,000 live births. It's more common in males than females. The child will experience left lower quadrant pain and swelling, an accumulation of stool with distension, ribbon-like foul-smelling stools. In newborns, they may even fail to pass meconium. And then enterocolitis really is our concern. So this is where there's inflammation and infection of the intestines and the colon. So watch for things like fever, increasing abdominal pain, and diarrhea. Nursing considerations for patients who have had surgery, like for the Hirschsprungs, would be teaching and prep. So educate the parents and the patient, depending on the age, about bowel prep if needed, the use of TPN prior to surgery so the patient can be NPO, fluid and electrolyte replacement, low fiber, high calorie and protein diet, and then monitor for signs and symptoms of enterocolitis complications like shock. Encourage and promote parent-infant bonding. Post-operatively, abdominal care, wound care, dressing changes, ostomy care, Foley if needed. If they're diapered, you place the diaper below the dressing as seen here. And a lot of this is just going to be teaching the parents how to care for their child as they are changing and growing. So that's all I have for you today. Thanks for watching, and I hope you enjoyed this video.